And it is, for me, also an incredible privilege to be a part of this panel because these are the amazing leaders in the field who I have just continued to follow and learn from. So it is just a real privilege to be here. So let's see, that one right up there. Perfect. Thank you. So the instructions for Michelle were to really tell the story about one particular clinical intervention that we've been working on, but really to tell the story about how you get from kind of early intervention development into starting to think about potentially scaling up an intervention. So this is less a research presentation and more about kind of a particular journey for a particular group of us that includes Michelle Decker. She and I have been at this since Michelle was in graduate school, I think. So first, I have no relevant financial relationships. However, full disclosure, also following Jackie, I do work very closely with Futures Without Violence, and I absolutely endorse their work. So that is the full disclosure part. So the one public health issue that I'm going to focus on for the next 20 minutes is unintended pregnancy. And as you all know, here we are in the School of Public Health. This is a major public health issue. About half of the pregnancies in our country are unintended, meaning mistimed, unwanted, or unplanned. And for teenagers, that's about 87% of adolescent pregnancies ages 15 to 17 are unintended. And the data is very, very clear that unintended pregnancies are not good for mom's health and not good for their infant's health. And the work, this is building on 2 decades of really amazing research, much of it led by Dr. Jackie Campbell, underscoring and Dr. Ann Coker on violence and reproductive health. And it is that linkage that we started to look at. We knew that pregnant adolescents were 2 to 3 times more likely to have experienced violence during and after pregnancy than older pregnant women. And there was ample data looking at relationship abuse and sexual risk for adolescents. So unplanned pregnancies, STI and HIV, rapid repeat pregnancies. I don't need to go into all of the data except to say we knew a lot from the descriptive work that had been done. And so the very first study that Michelle and I embarked on was interviewing young women who'd had histories of abusive relationships. And in the course of about 60 plus interviews, we heard stories like this. The first couple of times, the condom seems to break every time. You know what I mean? It was just kind of funny. The first 6 times, the condom broke. 6 condoms, that's kind of rare. I could understand 1, but 6 times? After that, when I got on birth control, he was always saying, you should have my baby, you should have my daughter, you should have my kid. He was a young woman who was already a mom at the time we interviewed her, and she actually went to the clinic to ask for the Depo-Provera injection so her partner would not know that she was on birth control. And then we heard another similar story. I was on birth control here. It's oral contraceptives, and I was still taking it. He ended up getting mad and flushing it down the toilet, so I ended up getting pregnant. I found out that before this, he talked to my friends and told them we were starting a family. I didn't know that. I didn't want to start a family. I wanted to finish school. So we had stories. About a quarter of the girls we interviewed told very, very similar stories about explicit attempts by their male partners to impregnate them. And we said, wow, how about that? Because guess what? That wasn't in any teen pregnancy prevention program materials. Right? We then went on, the Guttmacher Institute approached me and Rebecca Levinson about doing the same study, Rebecca Levinson from Futures Without Violence, about doing the same study with adult women. We interviewed well over 70 women, all with histories of physical or sexual violence at the hands of a partner. 3/4 of the women described this pregnancy controlling behavior that we are now calling reproductive coercion. So an example of this, by telling me not to use it, like when I had the pill, he used to act out and ask me why I'm using them. I'm hiding to use it and stuff like that. Then there was another time I started using the ring, and he pulled it out of me. What's this? Who advised you to be using this kind of stuff? I was like, I thought I could actually hide this one, not knowing you will come up inside of me and pull it out of me. We have subsequently heard stories of women having their IUDs pulled out as well. And so this is explicit birth control sabotage as well as sort of pregnancy coercion. So this term reproductive coercion is what we sort of landed on. Initial papers that I wrote about this where I used the word reproductive control, but really it was counter to sort of my sense of reproductive justice, which is that women ought to have control of reproductive decision making. And so in really trying to land on the right language, have come up with this term reproductive coercion to capture the birth control sabotage, pregnancy pressure to get pregnant, but also pregnancy coercion, which is controlling the outcomes of the pregnancy, threatening abortion and or threatening to hurt her if she doesn't continue the pregnancy. And so it's this sort of umbrella term for this. So then we get to intervention development. So I was living in Boston at the time, working with Michelle Decker and Jay Silverman and others at Harvard. And as I was presenting this to our family planning counseling colleagues, these are the amazing nurse practitioners and physician assistants who work in school health centers, who work in freestanding family planning clinics. And I'm presenting this data, and they said, OMG, Liz, you need to do something about this. And I said, and exactly what are we going to do about this? And so this was really community-based participatory research. At the time, I had never thought about how to develop an intervention. And what the family planning counselors and clinicians suggested was, how about a series of scripts? Like, we've never actually asked women at the time they're coming in for a pregnancy test. So if this test is positive, how's the person who's trying to get you, or how is the person with whom you're having sex going to react? Is it possible that that partner is actively trying to get you pregnant when you don't want to be? Right? So it was this notion that instead of our usual domestic violence screening questions, that we start to think about integrating it into the reproductive health visit. And so we came up with a script for pregnancy testing, one for emergency contraception, one for the well visit in general, one for STI testing, one for STI diagnosis. Like, every single visit we had a special script. And then they blew it up into like 20-point font, laminated these, and had them in every exam room. And it was really quite exciting to see this kind of intervention as it was developing. We applied to NIH, and it was in a day when it was a little bit easier to get money out of NIH. And we got pilot funding to do this initial pilot study of a family planning-based intervention. What was interesting was, by then I was driving my gray station wagon across the state to California to start my new job at UC Davis. And I get a call from the Massachusetts State Department of Family Planning saying, so good news, we've decided to mandate this intervention with every family planning provider in the state of Massachusetts. I said, well, that's interesting. How am I supposed to do this randomized study now? And so, there goes the advocate and the researcher in my head talking to each other. And I land in California and, amazingly enough, meet Rebecca Levinson at Futures Without Violence. At the time, it was the Family Violence Prevention Fund. She goes, well, that's easy. I used to be a director for Planned Parenthood for the last 10 years before I became a violence prevention advocate. So why don't we just call it Planned Parenthood? And sure enough, Planned Parenthood affiliates of California signed on, and we moved the study to California. And just to for the geeks in the room, the intervention was sort of a threefold piece, and I hope reflects the language that's in the IOM guidelines, which was this notion of an enhanced assessment for partner violence and reproductive coercion, to offer harm reduction. So if she's there and saying, yeah, he is messing with my birth control, to say, well, here are some birth control options that he can't mess with, that he can't interfere with. So there's a harm reduction piece as well as a safety assessment. And then the third component, and probably the most critical, is the partnership with local domestic violence and sexual assault agencies. It's the piece of the IOM guidelines, too, that it's a hugely important piece. I worry with all of what's going on with VAWA that that is the piece that, policy really matters. And if there is not a funding stream to support violence victim services, we cannot do this work in our clinical settings. We have to have our advocates side by side with us. So it was sort of a tripartite intervention, and I brought examples of the safety card, this is really on the shoulders of Judy McFarland's work that showed that the provision of a safety card could have a very, very significant effect in increasing women's safety. And so it was it's an 8-panel card, but very targeted towards reproductive coercion. So rather than, as you see, does your partner mess with your birth control being one of the questions. So this is a intervention that is not sort of for everybody and all comers. This is about heterosexual young women of childbearing age seeking care for reproductive health. Okay, it's like a tiny, narrow wedge that this intervention was directed towards. We created a pregnancy wheel. Can't read the print down there. It says, was your partner trying to get you pregnant when you didn't want to be? So this is a pregnancy wheel that they often use in the family planning setting to date when the pregnancy is expected, for doing dates, and it was just putting some prompts in places that providers could use. Here was another one. Are you worried he will hurt you if you don't do what he wants with the pregnancy? And as well as posters talking about longer-acting reversible contraceptives. So what did we find? In the family planning setting, whoppingly high prevalence of partner violence. So this was physical or sexual violence at the hands of a partner was over half of the women walking into family planning clinics. 25% reported having ever experienced reproductive coercion. And what we found, what was super duper exciting about this small pilot, and I say small because it was in 4 clinics, 2 got the training and 2 did not. For women who experienced recent partner violence, we had a whopping 71% reduction in the odds for pregnancy coercion compared to controls, as well as a trend towards reduction in birth control sabotage, but not statistically significant. And then there was a third finding, which we were really not quite anticipating, and it was really post hoc. We asked women if they were still in the same relationship, and if not, why not? And what we found out was in the intervention arm, regardless of whether they had said that they were in an abusive relationship at baseline, regardless, for all women receiving the intervention, they were 60% more likely to have left a relationship because it felt unhealthy or unsafe. There was nothing in the intervention. It's a brief harm reduction intervention. It was really intended to empower women with information. Nothing in the intervention that was about leaving the relationship, but again, really underscores the critical importance of providing women with education and resources. So we are currently conducting the 25 clinic cluster randomized trial in family planning clinics in Western Pennsylvania. How we got to Western Pennsylvania is another really interesting story about scaling up, however. So we have this pilot study data, and we went back to NIH and said, look at this cool pilot study data. And they said, you're right, it is kind of cool. Here's the money to do the larger study, which was super exciting. We were going to do the study in Northern California. And then true story, and then I will stop. Mid-February of 2011, last year, I signed my contract to move to the Children's Hospital of Pittsburgh. 2 days later, I got a call from my colleagues in California overseeing family planning for the state saying, so we're sending out the intervention materials, the beautiful intervention materials, to every family planning provider in the state. And I said, that's lovely, however. Again, advocate, researcher conversation in my head. I said, wow, that's exciting. And then I had my moment of panic of like, wow, so now we have this $2 million grant from NIH to do the large randomized study. What are we going to do? And on Thursday, 3 days later, I received an email completely out of the blue. Said, dear Dr. Miller, we've read about this intervention. We're just starting to explore some work around teen pregnancy and partner violence in Pittsburgh, Pennsylvania. Would you please send us your papers? And if you ever have an opportunity to visit Pittsburgh, would you please look us up? So it was this very small, lovely foundation that supports the health of women and girls in Pittsburgh. I immediately emailed them back and I said, well, here's my conundrum. And I don't want to presume that you would at all be interested in this intervention. It really did start with community partnerships, but now I'm going to find myself landing in a very different community. 2 weeks later, they pulled together a community meeting of the local domestic violence and sexual assault advocates and our 2 family planning providers in Western Pennsylvania. And several weeks later, I had enough letters of support to go to NIH and ask them to move the study. And so we are up and running. We've got now 2,400 women enrolled field, aiming to enroll 3,600 women across 25 clinics. And as you can see, what our primary and secondary outcomes are. Unlike the pilot, we hope to follow women out for 12 months with the goal of really looking at unintended pregnancy as well as reductions in violence victimization. So I will pause there, but just to sort of tell, a particular story about a small intervention, but that we hope is going to start to make a difference, at least in the reproductive health setting.
We can take one or two questions right now, and after the break, we'll have an opportunity to ask all of the panelists some further questions. So if anyone has a burning question.
Hi, it's a really exciting intervention and very worrisome for the women and girls. I'm wondering if there's a piece of your intervention that's geared for boys, for adolescent boys.
Absolutely. I don't have the right slides, though. So there's actually a fair amount of work that we're doing with boys. The primary prevention work that we're doing actually has been with coaches. So we're working with coaches both of high school and middle school age male student athletes to do a program that's called Coaching Boys into Men, also run by Futures Without Violence. And our results from the high school randomized trial in Sacramento showed that boys whose coaches talked to them about stopping violence against women and girls have greater intentions to intervene, as well as more positive bystander behavior, getting to what Anne was talking about earlier in terms of bystander behavior. It's an unabashedly gendered program. Right? It's about taking masculinity and sexual violence and saying they don't belong together. Right? So aggression on the football field never belongs in a relationship. Like very simple messages that coaches, no matter where they are on the sort of span of equitable gender attitudes, they can at least sort of espouse those simple messages. And then we also just got funding from the National Institute of Justice to do a randomized trial in school health centers in California, where we're taking a kind of universal healthy relationships approach that is somewhat more gender neutral, but then also offering the targeted assessment around reproductive decision making, specifically for girls seeking care in the school health centers. So I say that because we haven't really figured out what the right interventions need to be in the clinical setting for young men. I do a lot of my clinical work in juvenile hall, where I have young men. Just last week I had a young man who said he'd had 70 female sexual partners, and when I asked him, I said, so how many, are you attracted to men, women, both? And we're having this conversation. He goes, girls, just girls. He goes, so you're asking me how many bodies? That was when I was asking about the number of sexual partners, he said number of bodies. How do we start what's a meaningful intervention for me as a clinician at the time? Of course I want to talk about respect. Of course I want to talk about safety in relationships and condom use and all of those things. And yet for him, his experience of sexuality has been about engaging with bodies, with female bodies. And so I'm really grappling with what we need to do in the clinical setting for young men. In many ways, offering a young woman an IUD feels to me like something I can sort of concretely go, okay, I did a little bit of harm reduction today. It's so much harder for me to figure out, and I love to hear from all of you about what we need to be doing with young men in the clinical setting for them to understand the critical importance of respect and communication and healthy relationships as they sort of grow in their sexuality as well. So.